As I look at healthcare and we think about taking care of people, one of the focuses that I have is less chemistry and more biology, right? We need less exogenous chemicals and really work a lot more with optimizing our own biology.
Many of us have gotten aggressively onto the bandwagon, and I think you and Jeff Bland are the two voices I'm hearing saying, whoop, 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 caution.
The culmination of all of that was to say, hey, when we take this SiPore liquid, we see improvements in the biomarkers like A1C, visceral adipose tissue, waist circumference, sagittal abdominal obesity, and we also see improvements in lean muscle mass, LDL cholesterol, and total cholesterol.
To help your patients better manage post-meal glycemic and lipemic spikes, check out Sigrid Pro. Powered by patented non-systemic SiPore technology, it acts as a meal companion, working locally in the gut to slow the breakdown of carbohydrates and fats and reduce metabolic stress at the meal. Many patients also report a felt experience, including steadier energy and improved satiety. Visit sigridpro.com/DRKF to create your practitioner account and receive 20% off your first order using code WEB20DRKF. Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And of course, today is no exception. I am really excited to be talking to two big voices in the functional medicine space who also happen to be dear colleagues of mine. And we're going to be talking about some cool science translated into clinically actionable, clinically useful stuff. Today with me is the amazing cardiologist moving into functional medicine, Dr. Sanjay Bhojraj and Dr. Alexis Gonzales. Dr. Bhojraj is helping redefine what cardiovascular preventative and longevity medicine can look like through a functional lens. And Dr. Gonzales has a remarkable talent for taking emerging research and turning it into immediate, practical clinical strategies. They both speak really plain language. And, I think we covered a lot of information that'll be useful to you in clinical practice almost immediately. Today's episode is sponsored by Sigrid, the makers of the amazing product SiPore, and we're going to be taking a dive into that, the origin story of SiPore, the preclinical and the clinical science behind SiPore, and why, likely it's something you'll be considering using in your clinical practice, as I am doing in mine. So whether you're interested in metabolic health, precision medicine, or you really love just seeing innovation in action and how we translate it into clinic, I think you're going to enjoy this episode. I've had the opportunity to really experiment with SiPore. And one of the things that I say to my patients all the time, actually, to my family, to my mom, who's always saying, should I take this? Shouldn't I? How do I know if it's working, et cetera, right? Is that not a question we get all the time? How do I know if it's working? I say, Ma, mark your calendar when you start. Reconvene in a month, think of, and just track, don't change them. And I say this to my patients as well, maybe not quite as casually as I do my mom, but so SiPore is one of those products that I 1,000,000% recommend we all need to kick the tires on. I and my team and my patients have really had a good time exploring the power of it. And so I'm excited to be with you both again here in the podcast setting. We did a webinar a little while ago and it was really highly well received. So I'm excited to get this message out to an even bigger audience about SiPore. So Lexi, I want to start with you on, just give me a little bit of the backstory. Like, why am I so interested in this? And then we're going to jump into mechanism and some of the science. So what is it? And why do we need to know?
Yeah, and I think you hit the nail on the head quite poignantly in that it's super easy to use. It's actually one of the, I would say, I don't know if this is the best word, but the funnest interventions to try, because you can pair it on to basically your current regimen without making very many changes. You can take it with whatever medications and food, but essentially I think Sanjay describes it perfectly. It's a perfectly engineered sand particle, in that it's a silica particle that's been specifically engineered not just on the size of the particle, but the actual pores on that particle. And what they've been able to achieve is that particular precise size selectively binds to digestive enzymes in our body, which blocks that ability of the digestive enzymes to break down food that we eat into macronutrients, which then cause what we would consider glucose spikes or issues with lipids on the back end. And so what we're really trying to do is buffer the metabolic stress that we typically get from food. And so what silica or what SiPore is essentially you take this meal level intervention and it allows you to buffer that metabolic stress on the back end. And so this technology was created by Tor Bengtström in Sweden. And essentially what he was trying to do is solve this issue of how we actually support people that are in this pre-diabetic range from progressing to diabetes. And so it started out with this initial, calling from him to actually discover a pharmaceutical that would be this effective for managing this type of patient case. And what he found is, we don't necessarily need to create a drug, but there's actually something really interesting about silica in and of itself that we can manipulate in order to work with our own physiology. And so what they did is they took the individual silica particles, they made it a very specific size, which was micron size, which is just big enough for it to not be absorbed systemically. So this is a locally acting intervention. Then they took that micron size particle and put in nanopore size pores on that particle all over. So if you look at the particle, it has all these very individual pores on there. Then they put it in two forms, so either in a powder form in a capsule or in a gel packet, which is their liquid form. And so when you take that with the first bite of food, it actually binds to amylase and lipase selectively, and only those two enzymes, no other fat-soluble vitamins, none of your other enzymes, no other food particles. And it actually blocks the ability of amylase and lipase to break down carbohydrates and fats. And so those carbs and fats that are sitting in your food actually go through your GI system undigested, so that way you don't get those glucose spikes or the absorption of fats. And so we can go through all of the science deeper, but that's really the main takeaway is it's super easy to take, it's non-systemic, it's locally acting, and it pairs really well with all of the other lifestyle interventions that we typically recommend for this audience, which is, lifestyle, dietary interventions and movement.
And if you have a CGM on, which I would recommend for any clinician or
Totally.
layperson listening, you can pay attention. You can do immediate tests. Here's meal here's meal with, here's meal without SiPore, and you can just look at your data. It's pretty extraordinary. It's actually wildly motivating. But you don't, I want to just clarify with you, you're not completely inhibiting the absorption of carbs and fats. They're not going away. I mean,
Correct.
that would be a massive problem. You're slowing them down.
Correct. So there's a really cool phrase that we talk about when we think about SiPore that I think patients really latch on to, which is you're slowing down fast food. And when we say fast food, we're really talking about modern food that isn't necessarily the whole plant-based foods that we typically think about. So when we think about fast food, we're thinking, very processed, high in inflammatory fats, super high in simple carbohydrates. So but just to your point, the ability to slow that down so that way you're not getting those really rapid spikes and the breakdown of these processed foods is really where SiPore shines.
I want to just throw in there, because I feel like there's some clinicians out there thinking that, well, if it's going to slow down the absorption of carbs, you're going to be having some gut issues promptly. We're going to circle back and you're going to drill into that in a minute. But the extraordinary thing is, if this is in your head, clinicians, that actually doesn't happen. And there's some very cool science around that we're going to get to in a minute. But before we do, Lexi, I want you to give us a little bit of the publications, and we will link to the publications on the show notes. And then we're going to jump over to Sanjay, and talk about using these clinically and specifically, in the context of the GLP-1 generation we're finding ourselves in. Mm-hmm. So go ahead, give me a little bit of the science.
Yeah. So what they essentially did it the right way, or what we would hope every supplement company and medical food would do, the thing when they bring these products to market to clinicians and patients. So once they engineered the silica particle, they did some preclinical studies to actually confirm, okay, is this actually selectively binding to the enzymes that we think it's going to? And so what they were able to achieve in these preclinical studies, in vitro studies, is that yes, the silica particle selectively binds to amylase and lipase. We also can see that it helps to curb those glucose spikes and how quickly carbs and fats are actually absorbed. Then they transitioned into preclinical studies in mice, where they actually showed, some indicators that we would see some reductions in visceral body fat, some increases in lean muscle mass, and then reductions in biomarkers like hemoglobin A1C and some improvement in lipid markers. So they use that data to then say, okay, let's take this into humans and prove that there's a safety profile, to your point, that it's not going to cause any GI issues. And also, right, for the SiPore liquid, we're getting up to 9 grams per day of the silica material. So can we prove that it's safe and that they're not just taking in all of these silica particles as they're taking it in with food? So they were able to rule out that it's systemically absorbed in these initial human studies. They were able to prove that there were minimal adverse effects. I mean, I see this also personally with taking SiPore with every meal, and that my GI symptoms actually improved postprandially, like less bloating, less of that like gut heavy feeling, especially after you have a super greasy carb heavy meal. And they were actually able to show that in those initial human studies. And just recently, which is super exciting, they actually were able to publish their first randomized controlled double blind placebo controlled trial in humans, the SHINE study, in the Lancet journal. So I want to drill down into that paper a little bit more because there's a lot of exciting clinical takeaways for our audience. But the culmination of all of that was to say, hey, when we take this SiPore liquid, we see improvements in the biomarkers like A1C, visceral adipose tissue, waist circumference, sagittal abdominal obesity, and we also see improvements in lean muscle mass, LDL cholesterol, and total cholesterol. So all of the things that we typically think of when we want to put someone on a GLP-1, except there's no injectable. They don't necessarily have to make major changes in what they eat outside of the basic, lifestyle changes. And what's super interesting about the SHINE study is there was no recommendation to change anything about what they ate or how they exercise. So it was really attached to the introduction of this SiPore liquid, which was just taking one of those packets with every meal, breakfast, lunch, and dinner.
Thank you for that. And again, we'll link to the show notes. We'll link to the publications on the show notes. Sanjay,
Yeah.
I know you are pretty excited about the SHINE too. And so if you want to bring any more of your thoughts in it, that would be fine. And one of your thoughts is the whole muscle conversation. So talk about that, but just link it into, everybody is talking about GLP-1s or wants to be on GLP-1s. They want a micro, they want a macro, everything GLP in the water, whatever.
Yeah.
And you've got thoughts on that as a cardiologist and just as a functional medicine, just, a brilliant thinker. But then also too on the SHINE, I want to circle back to the whole muscle loss issue, which is one of the big problems with GLPs.
Yeah. And I mean, I think well, thank you for that, Kara. Great to be here. Always just a pleasure to hang out with you and have conversations. As I look at just healthcare, right, and we think about taking care of people, one of the focuses that I have is less chemistry and more biology, right? We need less exogenous chemicals and really work a lot more with optimizing our own biology. And now, having been in practice for over 20 years, I've seen cycles of these medicines kind of come and go, right? There was the fat blockers, so you can't digest fats, and that led to gas with oily discharge. Famously, is what I thought was like a Saturday Night Live commercial, right? When they first started direct to consumer ads, and then and it gets kind of even scarier when we start then talking about bariatric surgery, which was very effective initially. And I've had anyone who's been practicing during this era has probably had hundreds of patients that have had bariatric surgery. But oftentimes, what we're seeing is if we're not dealing with the lifestyle issues first, right? Those very foundational functional medicine things. Oftentimes those patients that undergo whatever version of bariatric surgery, Roux-en-Y or gastric lip bands or whatever they're doing, will often have a precipitous gain back of that weight, right? But at the expense of the muscle mass that they lost through malnutrition, right? And now they've gained so much more fat, and it just makes it difficult for them. So, as I look at GLP-1s and this, revolution, I mean, I see the same thing, right? I've seen this history repeat itself again and again. is that when you just rely on a pharmacologic therapy or a structural therapy alone without optimizing the diet, without optimizing the lifestyle, without optimizing the mindset, you're just going to reverse. And we are now seeing that in the clinical data. So I think I read something, 71% of people are no longer on GLP-1s after a year, right? The cardiovascular
Wow.
benefit and all of that stuff reverses after 18 months. And we see that people actually gain weight faster when they've come off of GLP-1 meds than had they never been on one in the first place. So, we're seeing this initially, and now when we look at the mechanism of action, and particularly the one that scares me the most is the CNS, the central nervous system, affecting the pleasure and the reward system of the brain. So now we're seeing people with anhedonia, and you can't fall in love, and you're not happy anymore. And we are fundamentally altering humans in not a great way, right? So I'll just kind of preface this by saying with GLP-1s, I see them as a slingshot that maybe for a few months, 3 months, 6 months, like to kind of get you that initial kick. But this is not a lifelong therapy in my mind, right? It's like saying, well, you know what? Like I was on chemotherapy for this cancer, so I'm just going to stay on the chemo for the rest of my life because why not? It got rid of the cancer, right? I think we have to be a little bit more intentional. And as you look at the practitioners, particularly the non-medical people who are giving this out, I think it kind of falls into the category, kind of my hot take, good for business, bad for patients, right? So I'm just going to leave that as it is. So what do we need to do, right? When we look at people who have successful,
Wait a minute. Wait a minute.
oh,
That was a mic drop. I just want to thank you. That was
I
that
mean,
was that was that was so brilliant, very meaningful. Many of us have gotten aggressively onto the bandwagon, and I think you and Jeff Bland are the two voices I'm hearing saying whoop 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 caution.
yeah.
And now some of these longer term data coming in are what you're pointing out. That's very concerning.
Well, and anybody
Very.
who understands biology, like this is not a surprise, right?
Yeah,
I mean, like,
that's right.
and then when we look at what happens, I mean, I kind of famously call GLP-1s a medically induced eating disorder, right? Like you are if you're not doing it with intention, you're getting malnourished, right? Like,
Yeah,
and
yeah,
kind of the reason my hot take exists is I had surgeon colleagues in the operating room when these medicines first came out telling me they were getting more bleeding complications intraoperatively because patients were no longer absorbing
wow,
vitamin K and they couldn't make clotting factors, and we would check bleeding times and they would be prolonged. Like this is not a panacea. We need to be very cautious with this, right? And
yeah,
so in my clinical practice, then I'm looking for, okay, what are wins that we can give patients where they're feeling better, but they're not putting them systemically at risk. And that's why, getting back to the SiPore, I think it's just such a brilliant molecule because it is, first of all, chemically inert, it's silica, right? It entraps these digestive enzymes. And remember and for the clinicians out there, remember, you don't just like dump a bunch of amylase and lipase into your gut as soon as you eat. I mean, there's a period of time through which you're secreting, throughout your digestive process, amylase and lipase. So when we instruct patients how to use this, you take a few bites, you take the gel pack, which is like a power gel. If anybody's a runner or endurance athlete, that you would do, has a citrusy flavor. And so you're entrapping those digestive enzymes up front, but you're not blocking, to Lexi's point, the digestion because your body is still going to secrete amylase and lipase. We're just blocking that initial dump of enzymes, so to speak. So we're now prolonging that time through which you're digesting. We're slowing down that initial phase. And as we look at what I think is one of the greatest tools that we've been given in the metabolic world, continuous glucose monitors, right? We're learning so much about
yeah,
the glucose velocity. It's not just about the level or the spike. It's about how fast you're getting there, how quickly you're resolving your, time in range, time out of range, these
yeah,
mean average glucose excursions, all of these derivative data that we're seeing that we never saw before. If you remember, as I do, during the old
yeah,
stick your finger 3 times a day, that's
yeah,
like looking at a speedometer and saying, okay, when I was in my driveway, I was at 0 miles an hour. When I was at the parking lot, I was 0 miles per hour. How did I get here? Right? There's a lot that
right,
happens in between. And now we're able to get better insight, better data into what's happening during that in between time. And we're realizing that these spikes are not benign, right? These
yeah,
excursions are not benign. And, we call it metabolic stress, right? Which is, I think, what precedes metabolic syndrome is like, putting your body through so much. In the same way that, like, if you're an endurance athlete, right? I know you're a cyclist, Kara. So imagine like, cycling 100 miles without stretching out your hips, right? Like that's a lot of stress on your joint. And so, essentially that's what we're doing with our metabolic system is we're giving it these foods that dump glucose and therefore require a quick insulin hit. And we are wearing out our bodies in the same way if you had a paper clip and you wanted to break it, right? You'd put it under the stress back and forth. But now by tamping down those excursions, right? By cutting down those spikes, keeping in range longer with the same meal as Lexi mentioned. We're not even asking you to change what you eat, which I think is so important that I'll get to in a minute. But just doing what you're doing, but making it kind of more physiologic, easier for your body physiologically to address the food that's going in. We're seeing some remarkable data. She mentioned that SHINE trial, and you pointed out, Kara, one of the things that I think is the most important is we actually saw an increase in lean muscle mass, right, in
Right.
that trial, which if you think about it, we're not calorie restricting, right? But what we're doing is almost making your digestion protein forward because we're blunting fat digestion with lipase, carb digestion with amylase, but the proteases are working just fine, right? So you're able to break down the proteins, get them to where they need to go. So it's almost the physiologic manifestation of when we tell people eat protein first in your meal, right? So now we're actually doing that, and our bodies, at least in our clinical trial participants, are enriched by that, and we're actually seeing
And
it
you weren't
physiologically.
you didn't bump up the protein, and this is of course is in stark contrast to GLP-1s.
Yeah.
In their the muscle loss, the pronounced muscle loss. It's just so interesting to me. The
Yeah.
other piece I want to just layer in there, two thoughts. One is people who are eating more protein to bump up their muscle mass can have digestive distress. And I just want to hit home the really cool finding that this has not been associated with that. So even though you're moving up, you're basically putting them on a protein forward diet to use it's not necessarily high protein, but it's acting almost like high protein,
Right.
and they're doing fine with it. The other point I wanted to make, and then I'm going to turn it back over to you, Sanjay, is just to remind folks, because we moved through this quickly, that no, this product doesn't influence vitamin D absorption. It doesn't influence your omega-3 absorption. And if you want to speak to that, Sanjay,
Yeah.
as you talk more about it, you certainly can. But I just want to remind it because I know that's in folks' mind. On the webinar, I think we got that question at least a dozen times. So
Yeah, and
it's
I think that's such an important point, right? Because we don't. I mean, for me, again, I'm trying to influence biology here, not just chemistry, and we want to make sure that we're still getting what we need to get. And this is a mealtime replacement. So, if you're really concerned, you can alter your supplementation around that, right? So that if you're taking your vitamin D supplement in the morning, not within the window of taking a cigarette, SiPore pack, you're still going to get the normal absorption, right? And in the clinical trials that we did look at fat soluble vitamins and nutrition profiles, and we did not see any nutritional deficiencies or vitamin deficiencies as a result of the use of SiPore. So that's something that we are, very concerned about. But we've shown in clinical trials that that doesn't happen. And I know that unfortunately, people think it just stops absorption completely or stops digestion completely. Just to be clear, that is not the case, right? We're
yeah,
slowing down the absorption. So you're still going to get your carbs, you're still going to get your fats, just not with
yeah,
that same load, not with that same upfront kind of spike. And, clotting factors, fat soluble vitamins, all that stuff will still get in there, just not
yeah,
as quickly. And to Lexi's point, it's making fast food slow, right? And so
yeah.
getting them in, you're just not going to have those huge bumps and excursions and spikes that we see with the current level of diet.
And
It doesn't call.
can
Yeah,
I
go
just
ahead.
double click on that slowing down fast food? Because I want to make it super clear because this is also a common question we get. It's not actually affecting motility at all. So when we say slowing down your food, it's really just slowing down that absorption of the carbs and fats without any effect on your
Right.
motility itself. And so even though this wasn't an outcome that they were looking for in the SHINE trial, they actually saw benefits to the gut microbiome by delivering these like undigested carbs to the colon because you had slowed down that breakdown. And so they're going to drill down into those results with some post publication analysis of that cohort. But something exciting to look forward to, just because I know that's a question that we've all had is, what are the long term effects on the gut microbiome, and how do we think about this in the context of SIBO? with how we're adjusting absorption of these macronutrients. So I just wanted to double click on that point because it's important for those that are concerned about constipation or some of those GI effects with GLP-1s.
Yeah, no, that's awesome to distinguish it from SIBO just by bringing up the whole motility point. It's not manipulating motility. And Sanjay, to your point as well, this is not a gastric band, and it's not GLP-1. When you brought that up, that correlation, as I'm sure many listening, flashed to the patients that I've cared for who are malnourished, because they can't absorb, because, their stomach is no
cutting
longer
down your
existent.
stomach, like, are you
Yeah.
serious? That seemed like a
Yeah.
good idea to us.
Profound malnourishment. And it's not a part, nobody's tracked, nobody's tracked for the duration of the influence of that surgery.
Yeah.
So I think it probably happens, across the board.
And probably in the conventional system goes unrecognized as a source of
for sure. That was my experience.
And why am I getting demented? Maybe it's because of B12 deficiency, right?
Right. Crazy neuropathies. That's right. I mean, I think they pay attention to it, in the very short term, but then.
And I mean, that's a great point, Kara, because when we look at long-term data, right, in these clinical trials, it's 5 years, but people don't live 5 years. They live 50 years after surgery, right? So, again, to anybody who understands biology, it's the most obvious thing. Like, it's the most predictable thing in the world, right? It's like when I tell my daughters it's going to be cold outside, and like, no, but the sun is shining. I'm like, yeah, but it's 40 degrees outside. You can have sun when it's cold outside, right? Like, they don't have that frame of reference, so they go outside and they shiver, and I'm like, okay, you'll not make that mistake again, right? So it just we have to look. I think what I do when I look at patients is, all right, I'm seeing you today, but also if I'm a longevity physician, like, I'm trying to get you to 100, right? So what are the things that we're doing today in 2026 that will keep you healthy in 2056, right? And I don't want to paint myself in a corner today that I wish I'd get out of. And you just take some moment to think, right? Or maybe some time to kind of understand the long-term consequences of what you're really doing. And I just don't think that unfortunately, it's top of mind for a lot of patients because they just want to experience what they see, the whatever their star is on TV that they're watching, and it's up to us.
Huge.
All right, this is what you need to understand about that, right? Or this is the team they have behind them, making sure their nutrition is up to par. That we need to make sure that you've got that knowledge as well, because it's not just about giving yourself an injection, and it never should be.
Yeah. Thanks, Sanjay, for hitting that home. And you can keep doing it. I want to round robin on using it clinically. So I want to start with you, Sanjay, on bringing it into your patient population. A lot of folks with prediabetes, metabolic syndrome, on up to diabetes. So what that looks like, and then over to you, Lexi, and women's health, and how are you using it there? And then I've got a couple, of thoughts from my own experience using it with patients. So go ahead, Sanjay.
So for me, I'm a cardiologist by training, and now I focus on functional medicine approaches to cardiometabolic and cardiac diseases. So this is a bulk of the patients that I see. And when I explain what's going on, first of all, I think that my patients in particular are appreciative that it's not like a medicine, right? It doesn't affect your mitochondria, or it doesn't affect secretion of insulin or whatever, right? So, and what they also appreciate is that I'm initially not asking them to change their diet, right? I'm just like, just give it a go. And I think you kind of hit this in the intro. Give it a go, take it for a test spin and see how you feel, right? After a meal. Like, do you have to have that nap, right? Do you feel just kind of spent? Do you feel tired? Do you feel gross, right? And that felt experience of taking it is, I think, very different, because honestly, you don't feel different when you take 500 of metformin, right? You don't feel different when you take a statin, right? Whatever it may be. But here you actually feel something different without actually changing your diet. And I end up seeing a lot of Southeast Asian patients in my practice, being Indian. And the hardest thing to do is to try to change somebody's diet, particularly of my parents' generation, because they're so entrenched. And, I won't call out a specific family member, but I have a specific family member that I don't want to get in trouble on podcasts. Luckily, they probably don't listen to it. They don't really believe that I'm a doctor anyway, so I said, I don't think, she's like, I can't lose weight, my joints always hurt, this, that, and the other. And I said, okay, well, look at your diet. You're eating a bunch of fried carbohydrates, like it's no wonder that your thyroid, antibodies are high and your joints hurt and all this stuff. And let's move to a little bit more fresh fruits and more vegetables, which by the way are part of the Indian diet. But she just throws her hands up. She goes, "Well, what am I going to do? I'm just going to die. I don't want to. I don't want to eat it. I can't eat anything." I'm like, God, like it doesn't have to be that dramatic, right? But I think anyone who has Indian patients, we watch a lot of Bollywood movies, so that's where the drama comes from. But then it was nice to say, all right, don't change anything that you're doing, right? But now just take this gel, right, and see what happens and see how you feel. And she felt better. I mean, I'm not saying that her autoimmune issues went away and all that stuff, but she said, like, because I'm always trying a new supplement with her. And she goes, yeah, this time I felt like different. Like after she said I felt light, like she just felt lighter after the meal. And I think that's that felt experience. And so particularly as we try to, get those wins, early wins with patients when they can feel better
Yes.
by having a very low risk intervention, that's a win,
Yes.
right?
Mm-hmm.
And so with that particular family member, I was like, okay, let's just kind of stick with this for a while, and then we'll slowly start to incorporate other things. And it gave her that buy-in to say, okay, you know what, something that Sanjay's doing is actually not working, so I'm gonna right. Uh, and so I think that's very helpful. And then I think of I have another family member who's diagnosed with diabetes. Initial A1C in 1 year climbed from like 6.1 or whatever to 7.2. And the intervention that was taken by his conventional doc was go see an ophthalmologist and a podiatrist because we need to do diabetic checks and retinopathy checks. And then he calls me and was like, "Hey, what do you think about this?" I'm like, "I think this is stupid because there's so much that we can do, particularly with the trial, the data that we have from Shine. You can actually, get people from that insulin resistant phase out of insulin resistance. So you can act in that A1C 5.7 to 6.4 kind of phase, but you can actually see hemoglobin A1C reductions, and it's retraining the body, right? And I think that's such an important thing that's missed in the conventional world. So clinically, I love it as a first line intervention as I'm working on diet, as I'm working on lifestyle, which by the way is what we're supposed to be doing in the guidelines anyway, right? But actually giving people then that felt experience where they can feel the win. And when
Yeah.
you're dealing particularly with patients that are used to taking meds that never make them feel better, right? But you can now say, hey, with this supplement, you're going to experience this, and they actually experience it and see the difference. It's so important. And then if we can get them on a CGM, which I think is just one of the most important um, drivers of change that we see in metabolic disease, is that we can
Yes.
say, hey, look at the same exact meal, right? And this is in our
Yes.
and on the webinar we talked about our founder who went out and had a burger on day one and then a burger, and which is kind of funny because they're probably not accustomed to eating hamburgers, right? But like had a burger at day one, then took SiPore, had burger day two, and we see the complete difference in the glucose response on a CGM. You can see that difference, and now you
Yeah.
can feel that difference. So remember my parking analogy, where you have 0 miles per hour at the part in their driveway and zero in the destination. Well, now you've got the speedometer data from everything that happened in between, and that's really when you start to look at that. And then as we've talked about, Kara, before, looking at more advanced CGM metrics above and beyond just how much how many whatever milligrams per deciliter you've got of glucose, but actually looking at time in range, time out of range, spikes,
Yes.
all of these things that are now these derivative data that we're now learning the power of, right? You
Yes.
can really start to combine and make a difference. And I think that's really what shapes behavior is,
Yes.
people seeing when I, eat a bowl of ice cream, but I work out, this happens. But when I eat, when I have a protein shake or whatever and do that, so they can start to make those real-time correlations. And that's really where change happens. It doesn't happen looking at a lab 3 months after an event happened, right? It's like
Right.
time of flight, real-time data. And that's the experience that people are really getting with SiPore.
In the studies, like when do we expect to see a drop in A1C? Or is there a range?
Well, remember, A1C is your average glucose over 90 days, right?
Right.
So I think that, depending on which CGM you use, a lot of them will have like calculated,
Glucose
approximations
variability.
of A1C. So, I mean, certainly you'll see glucose changes pretty quickly. I think they probably take,
Yes.
I would
Yes.
guess, and Lexi, you may know, I would assume they have like 7 to 10 days of data that they need to collect before they can make that estimation calculation of the A1C. So, you would see the glucose change pretty quickly. But that A1C change, again, would take some time. But anyone who's been in the clinical world, you get that, right? You take an intervention, you have to wait not 3 months, but 6 months to see what happened 3 months ago. So it tracks what we're already doing clinically anyway.
Yeah. Anything to add to that, Lexi?
Yeah, I was just going to say what's cool is in addition to having it being easy wins, is I also think about them as being compounded wins, right? Because you can see the meal by meal difference where you could say, oh, I'm actually, blunting those glucose spikes. Then you take it out to a week and you're like, oh, I'm actually getting less spikes per week. I'm spending more time in range. I'm not having as many spikes while I'm sleeping. So by the time they get their A1C run, every 3 months, they're expecting a good result because they have all of the
because they've seen the data.
Yeah, and they're making changes before that, right? Because they're like, oh, this is working. I'm more motivated to actually engage with this plan.
I think the big crazy experience for me was basically repeating the founder's experience of the hamburger. For me, it was my daughter's, pancakes, which I stay away from. I don't eat them, but I decided to do. I've indulged in more challenges, perhaps, than I feel like admitting these days. But it's right there. If I've got a CGM on, the data are right there, and it's very, very exciting. The other piece that I just want to kick this back. I think actually Sanjay, if you have more to add, you can. Otherwise, we'll go to Lexi and talk about women's health. But the satiety is something you also observed with this, right, Sanjay?
Yeah, and again, that makes sense biologically, right? Is that if you're keeping food in the intestines longer, allowing for that longer digestive time, you're going to feel more full. That's why whole foods make you feel more full than fast food, right? And so we are now kind of mimicking that. But then also remember the signals that sends to the brain, right? I think that when we're eating a ton of fast food, those satiety signals, the leptin and all of the ghrelin and all that stuff, like that chemistry, that biology gets messed up, right? And so now, we're kind of almost, I guess, in a weird way, simulating or creating what should actually be happening, but then continuing those networks, letting the brain know that you're full, right? Allowing time for digestion, that transit time, so that you're not hungry for the next meal. We're blunting those spikes. I think those big spikes then lead to, that crash. Kind of famously, that's why I say I think donuts come in dozens, because you get that initial spike and then 45 minutes later you kind of feel like garbage. So to get through the day, you have to have another donut, and so you're just kind of pushing yourself through the day. But we are blunting all those responses, allowing that satiety, allowing your body to experience nutrition and digestion the way that it's designed to. And it just, the system just works a lot better.
For the majority of your patients, you're prescribing a packet with with 3 main meals.
Yeah, I mean, remember, I'm seeing cardiometabolic patients that are pre-heart disease, pre-diabetic, right? So I don't kind of play. I think that's the place that I'm most comfortable starting. And again, it's not much to ask. We're not asking them to do 20 jumping jacks, right? It's just before every meal, right? It's just, take this packet with meals. It's easy, and it almost becomes it. I mean, if you've used it, you kind of know. It almost feels weird that first time you forget. It's like walking out without a belt on. You're just like, something feels nothing bad is happening, but something just feels off. And again, the form factor is so easy. You can put it in a jacket pocket or a purse or whatever. So it's not like some weird thing. And whenever we go to these functional medicine meetups, or everyone's got their whole row of supplements pre-meal, right? that well, I'm taking this, and I'm you're not asking them to do a lot, right? And so it just works, and it's like mobile and heat stable and all the stuff. So it's just an easy thing to incorporate into your daily life.
I do have a pearl because I have a couple of patients, and I'm guilty of this too, who will like eat, get distracted, and leave half their meal, and then go do something, come back and eat. And so what I found is if you take the whole packet with that first bite of food, you may not capture that like second part of your meal if you get distracted halfway through. So if you're like a distracted eater, like I am and many of my patients are, is I may have them actually split the liquid packet or the capsules. If they end up noticing that their meals are spread out over like an hour or so and they're kind of nibbling throughout it. So you may not see as significant of glucose, curbing the glucose spikes if you eat in that way and just take the packet with the first bite of food. So that is one pearl, is to kind of split it out if you need to and you're that type of habitual eater.
Talk about your patient population and how you're using it.
Yeah, so, my patients would love to be on GLP-1s, but I primarily see a lot of patients who are trying to get pregnant or getting ready for surgery, so for endometriosis. And so because of that, we often have the initial conversation of if they want to start GLP-1s, but we also talk about the washout period that's needed, right? If you're trying to get pregnant or preparing for surgery. So SiPore is actually my favorite tool to give them because it's a really nice bridge where they don't have to add another thing onto their stack, which oftentimes plans for fertility and endo are just inadvertently massive because we're covering so many nodes of the matrix. So to be able to provide them a tool that allows them to keep doing everything else that they're doing, and we don't have to have a washout period before they get ready for surgery or go through IVF,
Mm-hmm.
is a gift that I am able to give to my patients. So, specifically for PMOS, or PCOS was the previous name, for those patients that are, in the pre-diabetic range or, have type 2 diabetes, SiPore is super effective, mainly because they're already working so hard to adjust their diet, but there are those sneaky things that they're just having those glucose spikes to that they're just not aware of. So we put the CGM on, and they're able to identify which of those foods are actually causing those spikes, and then we can give them an easy intervention to actually curb that immediately, where they don't have to pursue an injectable. The other part of my patients, are super interested in, pursuing those direct to consumer GLP-1 sites because it's so easy, right? A lot of them don't qualify to get the GLP-1s covered by insurance. So I have a lot of patients coming to me already on GLP-1s that they got through, a website because they could just get it within a week and they didn't have to go through any pre-authorizations, or it was super affordable. So getting them off of that medication, knowing that they did not have the lifestyle or dietary support as they were onboarding onto that medication. SiPore to me is the perfect bridge for them to get off of it super easily, where it's not as stressful for them to get those appetite signals back as we taper them down, but we don't have to worry about, the downstream effects of tapering them off, and them not changing their diet too much. So I like it a lot for a bridge and then also as an alternative to GLP-1s.
Okay. Awesome. Yeah. You're working with patients. Anything additional you want to uh, add,
I mean,
Lex?
I think that's a great
Or
point about splitting meals. It's funny. I talk a
yeah.
lot about mindful eating. I was like that guy that I'd have 10 minutes to eat, and I just kind of slammed it down and get called out to this emergency, that emergency. But again, that's bad for our digestive kind of vibe anyway, right? So I think that as we
Mindful.
look at those at like I get it, life is life, right? But you can take 20 minutes to just sit and eat.
My population, ever since we conducted our research looking at epigenetic age, using our diet and lifestyle intervention, my population has really shifted from just a typical functional medicine demographic to people who are uh, biohackers, longevity seekers. It's changed quite a bit, and it's been very fun. I enjoy it, but I enjoyed my practice prior to. But sometimes they're referred to as the worried well, this population. And one of the ways that I've used it, so they're already metabolically flexible for the most part. I mean, there might be some underlying issues actually usually there are some underlying things we're working with, but it's not the same kind of lift because they're putting a lot of intention into their health. And I still think SiPore has a place with this population. Because we can apps, it's almost like a spot use format. So they're metabolically flexible, they're not moving towards diabetes, but if they're doing a lot of traveling, or if they want to indulge, or if they're doing their kids pancake test or whatever, SiPore can just keep them dialed in. And I absolutely love it. It makes sense. And most of these people are already periodically using a CGM so they can see when they have their transgressions and, again, immediately get feedback on using it. So I like the spot use scenario that fits in with my population. And, for me, quite frankly, to your point earlier, Sanjay, I have some in my bag. I've got one of those little itty bitty, like, what are they called? Fanny packs, like the modern fanny pack. And I can throw some in there and I have them with me.
Mm-hmm.
Um, So I think all of our patient demographic, there's a place to use these appropriately, wisely, safely, et cetera.
Yeah, I think
And
I would just say with the spot use is that we don't really know long term what that does, right? So mechanistically, I totally get it. It's just, I don't know that, that's like saying I'm going to take some glutathione and go out for a night of drinking. Like that night of drinking will still have an effect on your liver, right? And so, but I think it does open up for the biohackers or I think it's just cool when you have a product like this to see kind of how it gets used in the real world, right? There's still a lot of real world knowledge and information that we can get from that. So yeah, it's interesting. Or athletes, that's another one that we've talked about as well, kind of how this is going to play out in athletes right now.
super interesting. Yeah,
We
absolutely.
have the data from the data that we have, right? And so we know
Yes,
use
yes.
case, but as this kind of filters out, like it'll be very interesting to see how this gets used and again, I think that when we look in terms of therapies, there's a very large therapeutic window here in the sense that you can't overdose. I mean, as far as we can tell, right? Like we want to stay within zones, but I think that the market, the right patient for this is such a wide demographic of people, right?
Yes.
And it's really, again, I just focus on the fact that this is not an internal, this is not a chemical that's working on your body to cause this interleukin to go up or down or whatever it may be, or this kinase or whatever, but rather just working on a very simple thing. It's a very elegant solution to what's going on, and we'll just see how this plays out.
And what if you're somebody who's ApoE44, and you're fine, you're healthy, but you're really mindful of what's going on.
Yeah.
And one of the most effective and important ways we do that is keeping ourselves as metabolically strong and flexible as possible. So, could this have a preventative place as well? And I'm going to kick this over to you, Sanjay, because this was a question I was going to ask anyway. What about using this in the context of a keto diet, or I mean, this kind of the sky's the limit
Yeah.
for helping with compliance on some of these difficult dietary patterns, but also maybe furthering the power of the ketogenic effect.
Yeah, I mean, I think first of all, and you said it correctly, I think, is that, ketogenic, it's an effect, it's a biochemical effect, right? So anything that you can do to prolong that effect or improve that effect will then show the anti-inflammatory and all the benefits that we know from a ketogenic diet. So,
Right.
there's no contraindication to a ketogenic state, in that sense. Now, I think that the use case, why would you use it in a ketogenic diet if somebody is maybe eating off keto, right? Because I think keto is like a marriage, right? You cheat once and it's over forever. So you have to be very, very like clear on keto, right? Like what we're doing. So, would changing the dynamics of the absorption of fat in the diet affect the ketogenic state? I don't know. I don't know that anybody knows the answer to that,
Slowing
but
it down. Right.
certainly is not contraindicated. It's just one of those things that I think opens up for future study, right? Because maybe this keeps you in ketogenic states. Again, maybe, I don't know, conjecture, but maybe this keeps you in ketogenic states for a little bit longer. Maybe this allows then, if you do have a little bit of a slip up on keto, to maintain that ketogenic state. We haven't
Yes.
checked, we haven't done that study, but mechanistically, again, it's just one of the most elegant solutions. So, I think there is a very interesting use case, athletes, that need to be glycogen kind of enriched for endurance
Packed.
work, right? Like, but at the same time, are you getting it to the right place? So I think of that, big bowl of spaghetti you have before you run a marathon.
Yes.
You're probably not really holding on to most of that. You're probably just letting it go out of your system. So does this allow for a more efficient glycogen load? Will this
Yes.
change as you're holding on to lean muscle mass as a lifter? I'm like, well,
Yes.
will this kind of improve my muscle glycogen to help me lift more? I don't know. I don't know the answer to that. I think
Right.
we're very early on in the
Right.
clinical trials of all this, and those are kind of very niche markets. But at
Right.
the same time, when we look at just the general cardiometabolic patient, the PMOS patient, that person that we are just struggling with in the clinics, it's a very easy intervention to get some improvement. And
And is it possible to be able to turn the volume down on the quantity of protein you're consuming because you're no longer competing for absorption with the other macros? So that is interesting as well. I mean, the whole keto data, we can get those data as easily. Well, we don't have continuous keto monitors at this point, but you can get keto data pretty easily. Actually, and you could just use a urine dip if you want to. So you could begin, although that's not quite that sensitive. So maybe if you're doing blood ketones, you can, and you want to, somebody out there has that data. And if you're willing to, certainly email me. I'd really like to know, or make a comment wherever you're listening to it. I'd super like to know. But to your point, I do think it's going to be really cool for us to, as clinicians, begin to experiment and maybe circle back with you both in another year and see what other research has come out. We'll look at the microbiome data, and we'll have all sorts of clinician experience, broadly in our space and beyond. Anything else that you guys want to add as we wrap up this conversation today? It's been really interesting, kind of exciting. It's always fun to kind of wax future and hypothesize on how we might use it, and it's safe, so first do no harm, and which makes these conversations really that much enjoyable. But anything to add in our final moments, Sanjay?
But I think for me, very few interventions are not systemically absorbed, right? Remember, the GI tract exists outside of our body, right? So it's not even inside of our body. So we're seeing that effect there. We're not absorbing it into our bloodstream. We're not changing the microbiome in any significantly bad way. But we are seeing improvements in A1C, which I think we all think are important. We are seeing improvements in cholesterol. We are seeing improvement in weight management. We are seeing improvements in muscle mass, right? Yeah. And I think that, with very little toxicity, safe enough to use in that pre-pregnancy, fertility kind of space, safe enough to use, prior to any surgery, elective surgeries or anything like that. So I think that it all becomes, it's a very safe intervention that makes you feel different. And that, again, I just move back to that felt experience. When you feel that difference, when you feel that improvement, it's just going to build on itself, right? When the pants fit a little bit looser, then you're more likely to stick to your diet. Now, we're seeing that again and again. You don't have to have a CGM, right? You just experience your life. Don't change anything. You'll feel better. And then you'll get your patients, you'll work with your patients to make those changes. And it's just been a really fun thing for me to see in practice.
Right. All right, Lexi, no pressure. Final word with you. Take us home.
Yeah, I would say, try it. I think it's like one of the very few things where you just get such a quick and fast and dramatic response to when you take it, whether you have a CGM on or not, that it motivates you to try it again and see how you can compound those positive effects. And so that would be my biggest takeaway, is if you have the option to just try it, even with one meal for one day, and then you compound that to a week, and then your 3 months for your A1C, you will see changes in those glucose spikes, and then the metabolic parameters that Sanjay just outlined. So I highly, highly encourage doing an experiment on yourself, because it is fun, it is interesting, it's enlightening, and it's motivating that you can actually get there without making these like super strict changes in your lifestyle.
And I guess if something else, you can get 2 days of pancakes out of it.
2 days of your daughter's cold pancakes. Yeah, 2 days of
waffles, whatever. Yeah,
sloppy pancakes. And I just popped into my mind, so I guess we're having other last words. But this doesn't mean you're stopping the berberine. It doesn't mean that you're stopping the metformin. Like all of the other interventions we're using, the various probiotics that are beneficial, along different mechanism, but in terms of satiety and so forth, and controlling blood sugar, all of those interventions, we don't just stop them. I know that those are thoughts in people's minds, but the clinician can pay attention, and adjust as you see benefit and move things around. So both, always, thank you so much. I look forward to seeing you both in real life, probably in December, and to continue, we'll continue this conversation. It's an important one.
Absolutely.
Thanks for having us.
Did you enjoy that conversation I just had with Dr. Sanjay and Dr. Alexis? I mean, was it not interesting and did it get the wheels spinning? Please, any ideas you have, if you're already using SiPore in practice, if you're thinking if you might bring it in, if you're, working and prescribing, restrictive dietary interventions and you think SiPore might help, I would just love to get your thoughts. If you enjoyed the podcast, anybody, please hit the like button, forward it to another colleague. And yeah, again, tell me what you're thinking about, how you might be using it. We are a community, and I do very much appreciate hearing from you, getting your ideas. And don't forget to jump over to the show notes for today's episode. You will get the transcription for free. And of course, the citations from Sigrid will also be there. We'll see you next time on New Frontiers in Functional Medicine. To help your patients better manage post-meal glycemic and lipemic spikes, check out Sigrid Pro. Powered by patented non-systemic SiPore technology, it acts as a meal companion, working locally in the gut to slow the breakdown of carbohydrates and fats and reduce metabolic stress at the meal. Many patients also report a felt experience, including steadier energy and improved satiety. Visit sigridpro.com/DRKF to create your practitioner account and receive 20% off your first order using code WEB20DRKF. Disclaimer. This podcast is for informational purposes only. If you have a specific medical concern or if you have any questions, please speak with your healthcare provider.